Hello everyone. Welcome back to today's series of lectures in pulmonology. So we'll be starting off with occupational lung diseases. So let's begin. So what do we understand by occupational lung diseases? These are basically disorders of the lung which arise due to chronic exposure to occupation-related hazards. Most probably this is due to inhalational hazards. Okay. So what are the kind of substances and how do they cause this lung injury? So what are the determinants of occupational lung injury? So inhalation of water-soluble gases. Inhalation of water-soluble gases like ammonia and sulfur dioxide, they get absorbed into the proximal airways and they can cause bronchoconstriction. So if there are people working in places where you have inhalational injury due to water-soluble gases like ammonia and sulfur dioxide, they cause proximal airway obstruction and hence they can present with episodes of wheezing, right? So they predominantly involve the bronchi or the proximal airways. Non-water soluble gases. Non-water soluble gases like nitrogen dioxide and phosgene gas, right? So these penetrate the alveoli, therefore they basically involve the lower respiratory tract and they can cause chemical pneumonitis. How does chemical pneumonitis present? Acutely it presents with adult respiratory distress syndrome with presence similar to an ARDS-like picture with episode of fever followed by ARDS. So, water-soluble gas inhalation can result in proximal airway injury and bronchoconstriction. Non-water-soluble gas inhalation can result in chemical alveolitis. So, if the particle size is more than 10 to 15 microns in size, then they are limited to the nose and larynx and they predominantly cause upper airway symptoms. If the particle size is less than 2.5 microns in size, then it predominantly involves the alveoli in the lower airway system and they can cause pneumonitis. Okay, so this is about the most important points about the determinants of what type of injury happens, right? So it depends upon the size, it depends upon the nature of the gas that is inhaled. So whenever we speak about occupational related lung injury, we divide the inhalational hazards into inorganic substances and organic substances. Okay, so we should be well aware of what all substances can cause occupational related lung injuries. So, under the inorganic category, we have asbestos, silica, coal, beryllium and heavy metal poisoning. So, asbestos, silica, coal, beryllium and heavy metal associated lung disease. So, under the heavy metals, we have aluminium, chromium, nickel, titanium, tungsten and other hard metals. Okay. So what we will be learning in detail is predominantly asbestos related lung injury, then silicosis, coal workers pneumoconiosis and beryllium related lung injuries. Never forget about the organic particles which can cause a lung injury. So this includes cotton dust, milling, Baker's disease, agricultural dust. So very importantly in farmers, never forget to ask about the exposure history. Okay, then grain dust and biomass exposure. So whenever you see chronic obstructive pulmonary disease COPD in a female patient, especially the elderly females, always ask about biofuel exposure because chronic biofuel exposure, cow dung which they burn or similar kind of biomass exposure also results in COPD. So COPD in non-smokers, so COPD in females, never forget your biofuel exposure. Okay. So what have we learned? We are learning about occupational related lung injuries. So whenever we speak about occupational lung diseases, we talk about what are the substances that can cause in terms of organic as well as inorganic. And this is a list that we should be knowing. So let us start off with asbestosis. Okay. So let us start off with asbestosis. So asbestos is basically available or in the earth in the form of the chrysolite, crocodilite as well as the amphibole forms. Okay, so these are the forms in which asbestos is available. So it's available as chrysolite, crocodilite and amphibole forms. So which occupational hazards can result in occupational lung diseases? So the occupation includes milling or shipbuilding, then pipe fitters, boiler makers, right? So always remember shipyard workers is the most common association with asbestosis. So milling, shipyard workers, pipe fitters, boiler makers, all of these people have risk of asbestos inhalation. and asbestos related lung injury. Now, you do not always have to be a worker in these kind of occupations. You can also have bystanders in that area, like painters and electricians who can also get exposed to these fumes. So, bystanders in that area. Then, when do you have community exposure? You can have community exposure, especially if you have exposure with landfills or asbestos from road surfaces. So, community exposure can also be there as a risk factor for asbestosis. Okay, so whenever you speak about any occupational lung injury, we have to understand which type of occupation can predispose to which type of disease. Okay, so always remember shipyard working, miller, pipe fitters and boiler makers. All of these individuals are at a risk of asbestosis, and you can have community exposure from landfills and road surfaces. Alright, clear? So, what are the clinical features of asbestosis? So, what are the clinical features of asbestosis? Asbestosis as a disorder usually occurs up to 10 to 15 years of exposure. So, it takes up to 10 to 15 years or chronic exposure for the disorder to take place. Fine. So, what are the clinical features? They basically present with long-standing dyspnea. They are basically present with long-standing dyspnea. Okay. So, whenever you do a chest X-ray or whenever you do a CT, the predominant finding that you will find is the presence of fibrosis. So, there is damage to the alveoli and can result in fibrosis characterized by bilateral ground glassing, and it predominantly involves the lower lobes, and you can find reticulonodular opacity in the subpleural regions, right? So, if these are your lungs, this is your subpleural region, and here in the subpleural region, the lower lobes, you find reticulations or lace-like pattern or network-like pattern with bilateral ground glass opacities in your asbestosis. Okay, so this is nothing but a form of interstitial lung disease itself. You will understand these patterns when we discuss more in detail in interstitial lung diseases. Okay, so this is a type of damage to the interstitium predominantly. Also, the characteristic feature of asbestosis is the presence of these pleural plaques. You can find plaques in the pleura. The pleura gets thickened, and this is a characteristic feature. Okay, so can you see here in this X-ray? You can see that there are some thickenings here, right? Similar thickenings which are present here. This is nothing but your pleural plaques. And can you see the infiltrates are more common in the lower zones, and you have a lace or network like pattern, right? So that is your asbestosis. You can more clearly see it in the CT. Can you see that there is subpleural reticulation? Subpleural reticulations predominantly involving the lower zone. And this thickening, can you see, is the pleural plaques or the pleural thickening. Pleural thickening. Alright, clear? Also, you can have something called as BAPE. So, what is BAPE? This is benign asbestos related pleural effusion. Okay, so you can have bilateral pleural effusions as well, which is called as benign asbestos related pleural effusions. Now, over the course of time, if there has been asbestos exposure for more than 20 years, there can be a high risk of development of carcinomas, especially lung carcinomas of all subtypes. So, you can have your squamous cell or your adenocarcinoma. So, if anybody asks you what is the most common malignancy associated with asbestosis, do not jump ahead and say mesothelioma, right? The most characteristic malignancy would be a mesothelioma. Most common is lung malignancies of all the subtypes, either a squamous or an adenocarcinoma. Mesotheliomas are one of the specific types of malignancies associated with asbestos exposure, and these can be seen in the lung or in the peritoneum. So, these can be seen in the lung as well as the peritoneum. And a characteristic feature is that they are not associated with smoking. So, these malignancies that we saw, the lung malignancies, if this is asbestos exposure along with smoking, then there is a high risk of lung malignancy. So mesotheliomas are not associated with smoking and they can arise even with short-term exposure to asbestos. So they can arise even with short-term exposure to asbestos. Okay. So how do you treat these kind of patients? It depends on which stage the patient is presenting to you. If the patient is presenting to you in the earlier stages, the most important step would be avoiding the exposure. So since this is an occupational hazard, we have to go every step and ensure that they are provided with masks, they are provided with respirators, and ensure that the exposure is less. And you can also monitor the levels of exposure and ensure that all the patients who have had a high level of exposure can change their occupation, or they are provided adequate safety measures. Okay. Now, if the patient is in earlier stages of the disease, you can give symptomatic treatment, give them bronchodilators. You can give them bronchodilators. But if the fibrosis has set in or if there is development of carcinoma, these are not going to be reversed and you have to treat them accordingly. Okay. So this is about asbestosis. The characteristic points about asbestosis that you have to remember is shipyard working and bystander exposure in painters, electricians, and community exposure even from roads. Okay. Then you will have to remember about the X-ray findings, pleural plaques, and then you will have to remember predominantly subpleural reticulations in the lower lobes. Then you will have to remember about mesotheliomas and carcinomas. Clear? So this is about asbestosis. So how do you diagnose your asbestosis? Just now we have seen that this is chest X-ray and CT scan, and the findings we have discussed, treatment we have already discussed. Let us move on to silicosis. Okay. So silicosis is also an occupational lung disorder which is characterized by exposure to crystalline quartz or free silica. So it occurs due to exposure to crystalline quartz or free silica. So which are the occupations that predispose to silicosis? Remember, mining, stone cutting, sand blasting, glass or cement manufacturing, and quarrying, predominantly granite. Where do you use granite? Most commonly you would have seen your granites on the kitchen tops, right? So granite quarrying is also a risk factor for silicosis. So mining, stone cutting, sand blasting, glass or cement manufacturing, and granite quarrying. So silicosis can be of two types. So first form is your acute silicosis. Acute silicosis occurs whenever you have high quantities of silica inhalation where they present acutely. So these present with acute onset of fever, cough with expectoration, acute onset of fever, cough with expectoration, and respiratory failure. Fever, cough with expectoration, and respiratory failure resulting in an ARDS kind of picture. The characteristic CT finding in your acute silicosis is what we call as this crazy pavement pattern. This is called as crazy pavement pattern. So the characteristic feature of acute silicosis is this crazy pavement appearance, and it is most commonly confused with which condition? Pulmonary alveolar proteinosis. So this is most commonly similar to PAPS or pulmonary alveolar proteinosis, and the characteristic CT finding is the crazy pavement pattern. So treatment for acute silicosis is actually a rare procedure that we do, where we do a whole lung lavage and you remove the silica particles. Okay, let us look at chronic silicosis and how does it present. So chronic silicosis is characterized by small round opacities in the upper lobes. So if it is without lung impairment, it is called as simple silicosis. So simple silicosis is characterized by small round opacities or nodules predominantly involving the upper lobes. Okay, and it usually does not cause lung impairment. So if there is no lung impairment, it is simple silicosis. Also, you can have calcification of the bilateral hilar lymph nodes. You can have calcification of the bilateral hilar lymph nodes, and this is what we call as eggshell calcification. This is seen in up to 20% of the individuals. You can have eggshell calcification of the bilateral hilar lymph nodes. Now, over the course of time, these nodules can conglomerate and result in masses which are larger than 1 centimeter in size, resulting in complicated silicosis, and here you have lung impairment. You do have lung impairment. So, you can have development of a restrictive lung disease. You can have development of a restrictive lung disease. Okay. So, initially you have small opacities in the form of nodules. This is simple silicosis. As it progresses, they conglomerate to form huge masses more than 1 centimeter in size with lung impairment, and is called as complicated silicosis. Over the course of time, as you can see in this CT, there can be large scale fibrosis of the entire lung, which we call as PMF, or progressive massive fibrosis. So, the end stage and chronic exposure to silica can result in progressive massive fibrosis. Always remember that this silica results in cavitatory lesions as well, and there is an increased risk of infections, especially with TB, non-tuberculous mycobacteria and fungi. And this is what we call as silicotuberculosis. So, always remember that long-standing silica exposure can be associated with an increased risk of tubercular infections as well. Okay, so this is about silicosis. Now let us move on to coal workers pneumoconiosis. Coal workers pneumoconiosis. So, simple coal workers pneumoconiosis, as the name suggests, it is associated with coal exposure. So, it's characterized by again nodules with no pulmonary involvement, and this also involves the upper lobe. So, they predominantly present with chronic bronchitis, and there is no pulmonary dysfunction. Complicated coal workers pneumoconiosis is characterized by again nodules more than 1 centimeter in size involving the upper lobes, and this also has an increased risk of progressive massive fibrosis. Okay. Now, what is Kaplan syndrome? So, seropositive rheumatoid arthritis patients can have pneumoconiosis as well. So, pneumoconiotic nodules with seropositive rheumatoid arthritis, that is RA, with coal workers pneumoconiosis, is what we call as Kaplan syndrome. Okay. So, RA with coal workers pneumoconiosis or pneumoconiotic nodules is called as Kaplan syndrome. So, the treatment of coal workers pneumoconiosis also involves reduction in exposure to coal. Provide them with adequate respirators, provide them with adequate personal protective equipment. Okay, fine. Now, let us look at chronic beryllium disease. So, when do you get chronic beryllium disease? So, this occurs with exposure to alloys, ceramic and electronics industries. These are the most common industries where you get beryllium exposure. So, remember the key word that beryllium exposure is similar to sarcoidosis. It is similar to sarcoidosis, and the test that we use to identify chronic berylliosis is the beryllium lymphocyte proliferation test. Okay. So, here what you do is that you can demonstrate in vitro proliferation of lymphocytes to beryllium, which is measured by radiolabel thymidine. This is a very, very important point. So, how do you differentiate sarcoidosis from beryllium associated diseases is that you do the beryllium associated lymphocyte proliferation test, BELPT, where there is in vitro proliferation of lymphocytes to beryllium and it is measured by radiolabel thymidine. Okay. So, how are these chronic beryllium disease going to present? So, chronic beryllium exposure will present similar to sarcoidosis. So, they present with dyspnea. You can find evidence of hilar lymphadenopathy. So, they present with long-standing dyspnea and you can have evidence of hilar lymphadenopathy. So, on histopathological examination, again you can find non-caseating granulomas and monocytic infiltration of lung tissues. So, the most important test to differentiate sarcoid from beryllium associated lung disease is your BELPT. Okay, clear? So this is about your various occupational related lung disorders. So this was a short session, but we have learned the most important points for the 4 most common occupational related lung hazards. Thank you.